After vaginal cancer, the next cancer we are going to quickly revise is the vulvar cancer. Vulval cancer again is a rare gynecological cancer. It accounts for around 5% of all gynecological cancers. Again, common in women who are more than 60 years of age, but it is sometimes nowadays also seen in younger women. In that cohort of women, it is usually associated with HPV infection. Any cancerous growth that is seen on the mons pubis, labia majora, labia minora, clitoris, vestibule, or the Bartholin's gland is classified as vulvar carcinoma. The lymphatic drainage is straightforward. It is to the inguinofemoral group of lymph nodes. There are three specific predisposing or risk factors which can lead to vulvar cancer: HPV infection, lichen sclerosis, and VIN, that is vulval intraepithelial neoplasia. Squamous cell carcinoma is the most common histologic type, accounting for around 90% of cases. Others include melanoma, basal cell carcinoma, adenocarcinoma, and Bartholin gland carcinoma. Commonly, it presents with itching, burning, or pain on the vulva. It may also present with a lump, ulcer, or a lesion. At times, patient may come to you with complaint of bleeding or discharge. In many cases, cancer of vulva is initially misdiagnosed as chronic dermatitis or lichen sclerosis. The diagnosis is made by biopsy. It can be either a punch biopsy or an excisional biopsy. To find out the local extent, MRI is done, and to find out nodal or distant metastasis, a CT or PET scan is helpful. To understand the FIGO staging, you need to focus for a minute. Stage 1 means tumor is confined to the vulva. Stage 2, when it extends to the lower part of urethra, vagina, or anus. Stage 3 is metastasis to the lymph node, and stage 4, it is about metastasis. But here is a catch. Even the upper part of urethra, vagina, and anus, if it is involved, it comes here in stage 4. Stage 1 is divided into 1A and 1B. And what is the cutoff? Cutoff is 2 cm wide and 1 mm depth. If it is less than 2 cm wide and the depth is less than 1 mm, it is 1A. If it is more than that, it is 1B. Stage 2 luckily has no substage. Stage 3 is further divided into 3 substages: A, B, and C. And remember, B for bilateral. If bilateral lymph nodes are involved, it becomes 3B. 3A means just 1 or 2 one-sided lymph node involvement. 3B means either bilateral lymph node or more than 3 unilateral lymph nodes. Irrespective of the number of lymph nodes, if the capsule is broken, it is called as 3C. As for any other cancer, 4A means involvement of bladder and rectum, while 4B is distant metastasis. In cancer of vulva though, as I have told you earlier, even the involvement of upper part of urethra, vagina, or anus is included as 4A. Surgery is the mainstay of treatment, which includes wide local excision or radical vulvectomy, with or without lymphadenectomy. For advanced disease, radiotherapy plus minus chemotherapy is used, and for unresectable or recurrent disease, chemoradiation is used as palliation. If this question is coming to your mind, that why surgery is preferred in vulval cancer despite being a squamous cell carcinoma like cervix or vaginal cancer, the reason are: first, the vulvar cancer is localized and slow-growing tumor, which is amenable to complete resection. Cervical and vaginal cancer often are detected late because they are deeper in the pelvic cavity. Moreover, it is less responsive to chemoradiation as compared to cervical cancer. And as you can expect, the vulva is sensitive to radiation, leading to high morbidity like ulceration, fibrosis, chronic pain, and sexual dysfunction. Thus, the first choice for vulval cancer is surgery. Let's revise it quickly. The most common type of cancer in vulva is squamous cell carcinoma. Typically, it occurs in age more than 60, but younger cases are increasing due to HPV infection. Persistent itching or a lesion warrants a biopsy. Surgery is the mainstay of treatment, and nodal involvement is the most important prognostic factor.